Hello, welcome to Biomechanics for Birth. I'm Molly and I've been a midwife for 24 years and I love the pelvis. It's something that fascinates me and it should fascinate all of us because babies come through a pelvis. And that's why I've been looking into it for many, many years. I just want to tell you a little bit of the background about how I came to teach this subject, and then I'll go on and tell you what to expect for this part of the course. So my own birth experience, my first baby, was back-to-back, occipital posterior. And that was tough. And I had complete belief in myself to be able to give birth. But sadly, I was in hospital on my back. It was a long time ago, and although that still happens. But I did manage to push him out myself, which I didn't realise was such a great feat for a first-time mum to be able to do that. And then I had 2 more babies, really easily. And of course, environment makes a huge difference, but still, the mechanics of it were very different. And it led me to explore that a little bit further. So I've always had that interest. And I went to Jean Sutton's study day in 1999. And Jean was the only midwife who was talking about how babies come through the pelvis. And that was really stirred up for me even further, that we need to know about this in more detail. Of course, we're not trained as midwives. We don't have that detail in our training. And then I trained some more, and I did spinning babies with Gail Tully. In fact, I invited her over to the UK when I discovered, well, my daughter-in-law discovered her. My daughter-in-law's baby, our grandson, was breech, and she did a lot of investigation about turning him, and he didn't turn, actually, in the end, but that's another story. He did come out very easily at home, unexpectedly at home. Anyway, she turned me on to Spinning Baby's website. I was really interested. I thought, this is fascinating. And I started to use the positions immediately because I could see that this was something that made sense. So had success running out of the birth room on the delivery suite, wanting to tell everybody, having a eureka moment. And since then, that was more than 10 years ago, I've been investigating it further. So Gail Tully, Spinning Babies, has got a lot of information. And then I did an advanced course with Spinning Babies again, with an introduction to into myofascial releases, and that was really interesting as well. But I needed more, and I needed it to be linking in with my own practice. So because I was so interested in it, everybody at work used to say, oh, that's one for you, Molly, at the handover, when there was somebody who was struggling with a very difficult birth process. And that was kind of tough, because we know that those births are fairly long, drawn out experiences and can be quite tough. However, I had a very positive attitude towards it, because I believed that all was not lost, that we could actually help this woman, this birthing person, to have a better experience and maybe even facilitate rotation for the baby. So I ended up having a huge amount of experience looking after the women in that situation. And I was very grateful for it, because it's given me the knowledge that I have now. Because you don't find this in the textbooks. They're not in midwifery textbooks. They're not in the childbirth arena. So on my exploration and investigation of this subject, I had to look elsewhere. And I found it in yoga websites, fitness instructor websites and journals, osteopaths, physiotherapists, Pilates, and they all discuss and know the deeper detail of the pelvis and all the connections. And I thought, wow, this is incredible. We need to know this because this is our business area. This is what we do as midwives. We facilitate and aid and support women going through this birth process. And this is really vital information, and we all need to know about it. So I applied it to my practice, and I got my information from, as I say, those websites and journals and research studies as well. And the other place I got my information from was from the women themselves. So asking the right questions gave me a huge amount of information that I could then put together with my observations of while I performed the crucial midwifery practice of watchful attendance. So this comes back to us sitting in the room knitting in the corner, but we're not really just, it's not that we are not paying attention. We are paying attention, but we're doing it in a very different way. And that's what I was doing when I had the great fortune to work in a birth unit. So I've had a lot of experiences in undisturbed physiological birth because that's my passion. I think it's really important that women are able to have a birth experience that is totally physiological. I think it's really healthy and beneficial. And if they want that, then I will absolutely support it, which really means just guarding the door and not having interference, unnecessary interference. And of course, it's a physiological process, completely normal, and my total belief in it allowed me to have the freedom to guard the birthing space. And of course, you see it at home births as well. So home births, you have undisturbed birth, and I had many of those because I love it so much. I put myself in a position where I could experience that, and that's where I worked. So I worked in a team where we had a lot of home births for about 5 years. So all in all, I probably had about 1,500. I've attended 1,500 births, and hundreds of them have been undisturbed physiological births. That is an absolute, not only an absolute privilege, but it's quite rare because we don't get that. But I sought it out because I really wanted it and I really felt comfortable in that situation. But it gave me that opportunity to, as I say, that watchful attendance and asking the right questions at the right time, gleaned all this information from the women and the birthing people that I attended. And so now, and I've been doing this for quite a few years, I'm able to recognise labour, even very early on, that is being compromised by a suboptimal position or a pelvic restriction. Because sometimes the baby is actually in a good position, but it's still not coming down, and that will be a pelvic restriction. Most of the time, it's going to be occurs when the baby's in a suboptimal position. So, what great opportunity! And I was able to, what I call, join up the dots, and I know that you will be able to do that too. You have a lot of information, a lot of experience probably as well. Even as students, you will have seen, you have attended those births. And when we go through this course now, you will recognise some of them and be able to put them together with that deeper understanding of the detail of this magnificent, articulated, architectural structure that babies pass through, which is the pelvis. Now, people used to say to me, because it was very successful, people would say, "Oh, Molly, can you go into that room and do your magic?" I used to laugh. I thought, "Oh yeah, that's funny," but it's not really. It's not funny because it puts it into the realm of mysticism that only special people can do. And I realized very quickly that no, I must stop this. We mustn't talk about it in this way because this is science. And everybody should know about this. This is how our bodies work. And just because we don't know about the detail of it and the way it works, and sometimes it works like magic because it's so quick and effective, but it's not, of course, it's not magic, it's science. And I made sure that I spoke to people about that so that we had that understanding that we all need to learn this, which has led me to create these courses. And I have to say they've been very successful. And I've been into NHS hospitals and private hosting of the course as well, and a lot of students coming because students are really eager to learn this. And also, even midwives 30 years in practice are saying, "Tell me about this, because this is a gap in our knowledge and we need to find out more." And here we are, we're just about to do that. I want to point out that while we're looking at the mechanical element of birth, we're not separating it from the whole, because the mechanical element is very much an integral part of the whole. It has an influence and it works in harmony with the other systems, like the neurohormonal system, and stretch receptors in the uterus. So if the baby's not in an optimal position, those mechanisms, those feedback mechanisms, are not working effectively. And this affects the whole of the labour. And it makes sense of the labour patterns that we see that are commonly associated with a suboptimal position, causing a labour dystocia. So we have to also remember that there are some women who they give birth really easily to a baby who is back to back. We might find that they come in, they get in the pool, and everything's normal and fine, and she gives birth easily, or relatively easily. And the baby comes out, and we say, "Oh, this baby is back to back, who knew?" And it's a surprise to us, but that was fine for her. Maybe that's the way she's built. And she doesn't know like that. Or she might struggle a wee bit, but it's not tough. It's not like it is for most people. And that's something that we have to remember. So this is not everybody. And this course is about, it's aimed for people who are having labour dystocia. So if you're not having labour dystocia and everything going well, we don't have to do anything. We just do our normal supportive practice. But we need to know more if there's labour dystocia. So exploring and learning about the biomechanical part of birth, it doesn't regard women and birthing people as machines. Rather, it looks to connect these systems, emphasizing that the whole is greater than the sum of its parts. So, what is a suboptimal position? And a suboptimal position is one where there is a greater dimension passing through pelvis. And that's commonly thought of as being an OP, a back-to-back position, occipital posterior. But in fact, there are many more positions that can cause difficulties. And flexion is key. So you can have a baby who appears to be in a good position abdominally, doing an abdominal palpation, but in fact the head is deflexed or perhaps even asynclitic. Asynclitic being cocked to the side like this, and deflection means that the baby's head is up like this. So if you actually, I mean, the way we're made is that the baby's chin is on the chest like this. And if you put your hand, do that now, and you put your hand on the crown of your head here, that is the part that's coming through, and it is really a lovely, neat. You can cut your hand right around it, and it's a small dimension, and it fits really, really quite perfectly through the pelvis. However, if it's deflexed, it's up like this. So let's just feel that. And this is what's coming through, and it's a much greater dimension if we add asyncliticism, cocked to the head, cocked to the side, and deflexed, and feel that what's coming through is a completely different dimension. So that makes a big difference to how we give birth for most people. But it's really difficult because we're not recognizing it during the labor. And therefore we're not, because we don't recognize it, we don't act early enough to assist these women who are struggling. And we don't want them to struggle. We want them to have the best birth possible. That's what we're doing. We're with women, we are midwives, we are facilitating normal physiological birth. And we rarely see it. We rarely see it for many reasons, of course, because it's medicalized. Birth is medicalized, it is in an institution, and it's rare to see a physiological birth these days. And we know that. And we know that many students talk about the difficulty of getting their 40 births to tick off for their training because they haven't seen a normal, straightforward birth. So I know that there are 3 main reasons for a disruption of the birth process. And the first one is medicalization. The second one is fear. And the third one is biomechanical. And you can have an overlapping of all those. So we'll go through this course where we'll identify clues that will help us recognize a biomechanical issue and separate it from the other issues. Another difficulty that we have is that the data is not there. So when we try to identify the position of the baby, we're using tools that are not totally reliable. And when doctors perform surgery, emergency cesarean section on a birthing person or a woman who has labour dystocia and is not dilating and goes to theatre, they commonly cite the reason as CPD, cephalopelvic disproportion, and that is very unhelpful. Now, while it's true to a certain degree, cephalopelvic disproportion means that the baby is not coming through the pelvis very easily because of the proportions, the dimensions, and of course they are disrupted if the baby is asynclitic, deflexed. Really, they should be writing that it's a suboptimal position that's been the problem, but they don't. They write CPD. Now, CPD is actually rare. Absolute CPD is rare. It is commonly cited for cesareans. And that's not helpful. And it's just not true. Much better if we knew the real reason, and then we can investigate that and recognize it better. Instead, women are told it's CPD, their pelvis is too small. The baby's too big. They've grown their baby too big. They failed. They failed to progress. These are words that we use all the time. These are the things that we say to women regularly, frequently, that their bodies are faulty. Now, their bodies may be out of balance, but they're not faulty. The majority are not faulty. And I'm very grateful to have hospitals. I'm very grateful to have medical expertise, machines that go bing, the drugs. They are lifesavers. But they're not for the majority, they're for the minority. And yet, this majority are actually having these interventions. The World Health Organization says that cesarean section should be maybe 15%, but we have it double. In many places it's 30%, maybe even 34%. It's been running at 25% for many, many, many years, and it varies in different hospitals. And this is unacceptable. We need to change this, and that's why we're going to talk about biomechanics of birth. So let's talk about the birth outcomes that we expect to see from someone who is experiencing labour dystocia caused by a biomechanical issue. So we have about 15 to 30%, it varies depending on the research, but 15 to 30% of babies will start labour in an OP position, a back-to-back position. However, 80% of them will rotate. That's a lot, and that's really good. But are we comforted by that? 80%, the majority will rotate. Are you comforted by that? Because I'm not. I'm not, because when might that happen? It might be the second stage. The baby may rotate in the second stage. That means that woman's had hours, maybe days, of a really, really difficult labour with a lot of interventions before the baby rotates. So I'm not comforted by that, because I want her to have the best experience possible. I want her to have the experience that she can have, which is, it can be comfortable. Why is it that you can have comfortable births? Why is it that we say, well, I had a painless birth, actually, my third, and pretty much my second, but my first one was pretty horrendous. So what's going on there? We want everybody to have a comfortable birth. If it's a physiological process, then we expect that to work well, don't we? And if it's not working well, then there's going to be a reason for that. Just like if you have a disruption with your gastrointestinal process, another physiological process, that's working really well. Your stomach actually, it starts at the sight and the smell of food, that process. And the biscuit you've just eaten, or the breakfast or whatever, will be being digested right now. And it will go into the intestines, which are many, many meters of smooth muscle that works in peristalsis, in waves. And we don't feel that. We don't feel it unless we have a problem. If we have IBS, actually, you might well feel that. You might feel a lot of discomfort and pain. And it's the same with heart. If you've got that heart's a muscle that pumps a huge amount of blood, really at high pressure, huge volume to every part of your body, and we don't feel it unless it's a problem. Now, I'm not going to say you're not going to feel labour and birth. Of course, we know it's very intense. It's very powerful. And especially for first-time mums who've never had that experience before, but hypnobirthing works. And it works because it takes that fear out of the equation. But it also helps us to create the best environment inside and outside for the neurohormonal process to work in balance. So if the pelvis is not in balance, then there's going to be a disruption. So for those babies that are not born rotating till the very last minute even, the rest may be born by cesarean section or forceps or 1-2s, and that's hard. That's quite traumatic, in fact. So OP position significantly increases the risk of a cesarean for both primates and multips, first-time mums and second-time mums. Obviously, first-time mums are more at risk of that, resulting in a cesarean, but still, overall, it's 4 times the likelihood for both first-times and second-time mums. That's quite significant. And if it's in second stage, in the pushing stage, that is the most dangerous time for a baby to be born, and for the mother as well. The incidence of the high head when the baby is not engaging at term is about, 22% will be caused by a suboptimal position. Now, these are the statistics that we have, and this is the research that's been done on this subject, but it's limited because it looks mainly at an occipital posterior baby. But we want to know more. We want to know more about flexion. We want to have more information about that. And studies are coming. Slowly but surely, we're looking at it with a slightly different eye. So let's look at the anatomy and physiology a little bit deeper. Now, you might recognize some of it. I suspect a lot of it will be new to you. And it's all really important that all these muscles and ligaments, it's really important that we actually understand how the pelvis is constructed. And then we can understand better that why babies become stuck. So we have the piriformis. I mean, this is one of the muscles that's coming from the sacrum to the top of the leg, to the top of the femur. So it's passing through the pelvis, and it stabilizes. It's one of the stabilizers, and it controls the hip joint and the sacroiliac joint. So I want you to know that you don't have to remember all the details, but you just have to recognize and acknowledge that this is a most amazing, complex structure, and understand that muscles are passing across and upwards from the knee through the pelvis, and downwards from the spine through the pelvis, and it's quite complex. And once we start to have that understanding and actually that respect for this wonderful piece of equipment, then we can understand better how babies can find difficulty passing through, because it is quite, it's not narrow, but there's enough space, given that it's illogical for women and birthing people to grow their babies too big to pass through the pelvis, unless of course they have diabetes or a medical condition that causes them to grow bigger babies. Generally speaking, we don't do that. I mean, it doesn't make any sense for us to do that. So the majority of babies are going to get stuck because of a restriction in the pelvis or a suboptimal position. And it really helps us to understand how that works. So the piriformis is really, where we'll be working with that later will be some of the positions that we use will include lengthening the piriformis so that we get a little bit more space, because that is what we're talking about, is creating more space. So releasing tension, creating a little bit more space in the pelvis, that is going to sort out a lot of problems. So again, it's not 100%, but for the majority, it's going to work. It's going to work a treat. So the piriformis is a really valuable, all of them are valuable, of course, but a really pivotal muscle in the pelvis that we're going to work with. And then this next slide is going to, you can see it's a very, I love it, it's very complex. We have muscles running down, which is the psoas, and that's attached to the, it's coming from the thoracic vertebrae actually, and most of the lumbar, and right through to the top of the femur. And this is a really very important muscle in childbirth. Actually, we're talking about that more in the advanced course, but for the moment, we're just doing an introduction so you know that it's there. And it controls, well, it manages movement and controls front to back motion. And it joins up with the iliacus, and the iliacus, as you can see in the picture, is actually in here. So that's the muscle that's attached to the inside of this lovely hip bone here, the ilium. And the psoas runs through and joins up, and then of course becomes the iliopsoas. And that influences abdominal organ functioning, and the viscera and the nerves and the balance of the pelvis. Now there you are, abdominal organ functioning. What's an abdominal organ? The uterus. It's going to have an effect on the functioning and the position even of how everything sits inside the pelvis. Then you have the gluteus maximus, and that helps to control front to back balance along with the psoas. And this is a really large and powerful hip extensor. And look at that. I absolutely love that as well. The huge muscles in the backside. And there's the gluteus maximus, medius, and minimus. And look, it's all lying in layers. And you have in that slide, you can see the piriformis is coming. This is the back of the pelvis. So the piriformis is joining, attached to the sacrum, and then reaching through to the top of the femur. And there's other ones, obturator, internus, and others. Now, do we learn about that in our training? Have you heard about those? Do you know those muscles? You may well have heard of some of them, but how much emphasis was put on their function and where they are in the pelvis? I would suspect there's very little. And then we have the pelvic floor. Pelvic floor is amazing. Levator ani, the puborectalis, pubococcygeus, iliococcygeus. And these are really important. That's the pelvic floor. And do you know about them? Yes, you do, don't you? So we were all trained to know about the pelvic floor. So why is that? Why do we know about the pelvic floor, but we don't know about the piriformis? Just have a moment to think about that. Or the psoas, or the adductors. The adductors coming up from the knee, the inside of the thigh, right through to the hip. We don't know about them. We didn't talk about them, did we? And yet they're really important. And they influence the pelvis. And in fact, they will influence certain people, certain sports that will maybe get that a little bit more tight. And that will influence their pelvis and how they give birth. But we don't learn about that. But we do learn about the pelvic floor. Why do we know about the pelvic floor? Can you think? So I'll tell you, we learn about it because it's about pathology. It's about tears. It's about repairing trauma. It's about cutting episiotomies. It's about prolapse. And that's pathological. And so our training is very much focused on the pathology rather than salutagenesis, which is about health and the maintenance of well-being. And this is what we need to change in the way we are trained as midwives and doctors. We need to be looking at maintaining health, recognizing imbalance, and supporting the body to rebalance itself through techniques like the ones you're going to learn, or other measures, other therapies. It doesn't have to be based on pathology. Pathology has a place, but it doesn't have to be top of the hierarchy of learning. So then we have the ligaments. I absolutely love the picture with the ligaments in the pelvis at the back. And as you can see, there's a lot of ligaments that come across here, holding this sacrum in place. And there's very little muscle. We don't have muscle. And if you had to feel now, feeling your pelvis, you could do that now. Feel your hip bone. Feel where your pubis is. Stand up and have a feel. And feel your back, feel your sacrum. And you can feel those knobbly bits, the vertebra. It's all fused in the sacrum. It's a bit knobbly because it has no muscle, very little muscle at all covering it, but it's got all these ligaments that are crossed over, keeping it in place. Because if it wasn't kept in place, well, it would just move around like this, be flying all over the place. So it has to have some stability and balance, and that's created by ligaments. And these ligaments cover the pelvis, especially, of course, this area here. And they attach to different parts of the pelvis. And you see this here. There's the ischial spine. And what do we know about the ischial spine? In our training, all we know about that is that it's an imaginary line about where the baby's head is when we do a vaginal examination, where ischial spines. We're not feeling them. Usually you won't feel them. So we have to imagine this place, this line. It's not very scientific, is it? What we don't know, and we're not told, is actually a ligament attachment point. So as you can see in the picture, there's a ligament that attaches here at the ischial spine, and it attaches to the sacrum. Now, if that's tight, it's going to pull inwards, and then we might find that we can feel that ischial spine, because we know that's not a good thing if we can feel the ischial spine if you're doing a vaginal examination. But we're never really told exactly why that is. And of course, because it will be a possible restriction. But I'd like to know more about that. I want to know about it, and I want to know how to resolve it. And this is what we're going to be doing later. So you can see the sit bones, the ischiotuberosities, they've got ligaments attached to them again, running up towards the and covering the sacrum. And you can see the sacrotuberous ligament, which is coming from, there's the tuberosity, this is the ischiotuberosity, which is your sit bones. And that's got a ligament called the sacral, as in sacral, tuberous ligament, there it is, holding that there. Now, that is, that can cause havoc, and that can cause havoc in the second stage if it's tight and it's stopping the sacrum from tilting backwards, as in the tail coming backwards, increasing the space, the outlet. And we're going to talk about that a bit later. Certainly in the advanced course, we go into that a little bit more, but you're going to learn techniques that are going to release tension in those ligaments and muscles that we'll be talking about later on in the course. But we haven't finished yet. I mean, there's more that we need to know about and understand. This wonderful picture of those ligaments. I mean, that is, it's a piece of art, really, isn't it? So we have even more ligaments now. We have the suspensory ligaments, uterine suspensory ligaments. Very important, and again, we don't really talk about this very much, and yet they're so important. So we have the broad ligament that drapes over the uterus and the fallopian tubes and fixes onto the sides of the pelvis and the floor of the pelvis, and that maintains good uterine position. The round ligaments, those are those flat bands that stretch down from just below each side of the fallopian tube, down and through the labia, keeping maintaining optimal uterine position. That's bringing it into a slightly anteverted position. And the uterosacral ligaments, which are exactly as I say, attached to the uterus, the lower end of the uterus in the cervical area, and they're coming like this, as a pair, and they're coming from the sides of the anterior aspect of the sacrum and attaching to the lower end, as I say, lower end of the uterus or cervical area. Again, maintaining position. And I want to just go back to the round ligaments. Now, the round ligaments, if you actually can think of, just to illustrate this better for you, kind of like guy ropes in a sense. If you ever been camping and you put a tent up, what happens if one of your guy ropes is tighter than the other, or one's slacker than the other? Can you imagine what happens there? So the tent's a bit wonky. So when you go into the tent, the space is reduced, and you have to tilt your head a little bit, just like a baby would in utero, because there's not enough space just to get into position. You come out, you straighten up your guy ropes, nice and even, your tent sitting up nice and optimally, and you walk in there, and now you've got space. And that's pretty much what happens in the uterus when the baby's trying to find an optimal position. Because the baby can't find the optimal position, it will get into whatever position it can do. And that may well be suboptimal, and it may well be asynclitic, deflexed, even while maintaining an occipital anterior position. So abdominal, it feels like that, but the head isn't, because of the nature of the obstruction. It could be anything, of course. And it could be anywhere in the pelvis, these obstructions and limitations and reduction of space. It could be high up and maybe that gets resolved and the baby comes further down, and there might be another one further down. So you may find that when you're using these positions and techniques, you may have to use a few more as labour goes through the labour. Generally you don't, but you can't, you have always got to suspect if it's not verticalization, it's not fear, then it will most likely be biomechanical. And so you just have to keep on trying. But we'll talk about that later. I want to talk about one more really important ligament, and that is the cardinal ligament. And again, it's a really important suspensory ligament. It's coming from the sides of the pelvis, from the side walls. And in the picture you can see there, you're looking down through the body, and you can see all those ligaments that we've just been talking about, including the cardinal or Mackenrod ligament, which comes from the sides to the middle here. It also joins up with the sacro-uteral or uterosacral, same thing, uterosacral ligament for a few centimeters. So it merges together. So can you imagine it's coming from the side? If you have a wonky pelvis on one side, that's going to affect the tension and tone and balance of that cardinal ligament, which will reflect in the pelvis, in the uterus. Does this start to make sense now about why the baby gets into the suboptimal position? Once we understand, that's half the battle, isn't it? And I know that people say, oh, you've got a naughty baby on board, it's in an awkward position. I used to say that too, but putting the blame on the baby, the poor baby is actually trying to get into the best position it can. The babies know how to be born, it's in their blueprint, and they also follow signs within the uterus and pelvis so that they can do their negotiations through the pelvis. And if that's disrupted because of a biomechanical problem, then the baby can't do that. But as soon as that's released, the baby will take up that position very quickly sometimes and can be born. And then we have the baby actually passing. So it's not even, we're still on the pelvis. I mean, we're still talking about the pelvis. We have got the bones as well. So we've got the sacrum, coccyx, got the two big ilia, got the pubis at the front, which separates. It's got cartilage, it's got ligaments as well, and it's got ligaments coming from it. It's got the pubococcygeal. Remember, there's coccyx, there's the pubis, so this is running through, and then we have the organs passing the outlet of the organs, the bladder, the urinary tract, and the vagina and the rectum, all passing through that. And it sits like this. And of course, we have relaxin during pregnancy. We have hormones that help this all move around a little bit better, which is what we want. And we have everything that we need when we're pregnant and we're having a baby. So that makes a little bit more space and flexibility for this movement that is required to make more space for the baby. And in this picture where you can see, this is from Midwife Thinking, she discusses the space here, which is the brim or the inlet into the pelvis. And the baby actually, if I get my baby, moved it, I'll show you how that works. So the baby comes through the pelvis and will come through, let's go, sorry, go from this end. It's going to come in sideways because the shape here is generally wider in the transverse, more oval, and it will go asynclitic because the baby's going to negotiate, pass through, negotiate away past the sacral promontory. So it has to go asynclitic here to do that. And then it goes into the cavity in the midsection where it hits the pelvic floor. And the baby then makes the turn. There we go. So the baby makes that turn. Oh, I'll just finish that while standing up. It rotates, so it's gone in sideways, asynclitic a little while it negotiates the sacral promontory, hits the pelvic floor, and rotates. And now is looking at the screen and getting confused. It rotates, so it's AP, because outlet is wider in the antero-posterior dimension, and then the baby can pass through that way. Now, what happens, I think with all, especially experienced midwives, often say, quite rightly, that they see difficulties occurring in the pushing stage where the baby hasn't rotated. The baby's remained asynclitic, it's gotten stuck because it's hit that pelvis, it's come in sideways, maybe asynclitic too, negotiating past that sacral promontory, hitting the pelvic floor, but there's an tension, unexpected, different tension in the pelvic floor, which makes it more difficult for the baby to do that rotation. And so it gets stuck and it can't come through, and it's still quite high, maybe it's at the spines or slightly above, and it's not coming down. And now she's fully open, but it's just not coming. And you know, we're going to be learning techniques that resolve that, and resolve it very quickly, because once the tension is corrected to the proper tension that the baby needs to make that rotation, then the baby comes down. A sideline release is a really good one for that, so we'll be learning that. The other thing we need to know about the pelvis is nutation and counter nutation. Have you heard of that? Now, some of you may well have heard of that, but have you applied it to the childbirth process? Do you understand what that means? And that's what we need to do, is to apply it. So this is biomechanics, the study of human movement applied to the childbirth process. So there's a sacrum, and nutation means that it nods forwards. You see what it does there? Nods forwards. That's nutation. So when it nods forwards, the tail goes back, which means that this opens up. But not only that, the sacrum tips forward, the rib cage lifts and opens, the rings lean towards each other. That means that this outlet, is decreased in space, you see? But, sorry, the inlet, the outlet has increased in space because this flares out at the bottom and this comes back. So you've got more space, and in fact that's very handy for giving birth at the point where the baby has passed the spines, is coming down and are going to be born soon and can have more space to come out. Our body is made that way so it can happen really easily. Counter-nutation is the opposite. So counter-nutation, this goes backwards. They don't nod forward like nutation, it goes backwards. So it comes back and the wings flare outwards. So that's increased the pelvic inlet and making more space here. So when the baby's engaging and coming down, that's more spacious and easier to do, easier to happen. However, at the bottom, you can see when that happens, it reduces the space on the way out. Now, the women in the birthing table don't have to think about it. They don't have to think, oh, I need to go into nutation or counter-nutation. And neither do we. We don't have to consciously be thinking about that, but it's good to know about it so that we can step in if we need to give the hand in some way. So it's good for us to understand that. One of the things we do, and it's a very bad practice, we actually hinder the birth. Well, there's lots of practices that hinder the birth actually, but something that midwives do and doctors is we say, when the baby's starting to be born, we can see maybe a little bit of the baby's head or maybe even not, but she's pushing, and there may well be the baby's head there. And we say, open your legs. Open your legs, make some more space for your baby. So what does that do? Let's find out. Now you know about nutation and counter-nutation. I want you to sit on a hard chair, a firm chair. Because if you're on a sofa, you won't be able to feel this very well. So if you sit on a firm chair now, just wait a moment while you get that. And we're going to feel the ischial tuberosities, your sit bones. Remember, there's your sit bones there. So you have a hard chair there, or firm chair. I want you to put your hands underneath your buttocks, and can you feel your ischial tuberosities, your sit bones? Yeah. So hands there, knees straight ahead, parallel. And now I want you to pay attention to how the sit bones, ischial tuberosities are moving, because as the midwife says to you, as a labouring woman, as a birthing woman, open your legs wide and make more space. Let's do that. Open them wide, and what happens? They go inwards and forwards, reducing the space. But the midwife won't know that. The midwife thinks it's logical. Open your legs, open, makes more space, but it doesn't. Not in this circumstance, it doesn't. It actually reduces the space. But we've been put to a disadvantage because we have never been told that. And women instinctively will do this. They don't have to think about it. If they are left free to move, they will take up the position that is right for them. And generally, for most of those women, it will be a forward-leaning position. They will lean forward, they'll be on all fours, they'll be leaning on the bed forward, kneeling. Very, very many times that will happen, very often. And that means that the sacrum is free to move. Sometimes they'll lie on the side. I remember a woman coming in, first time mother, and she was fully open and had a student with me. And we didn't need to examine her or, do any of that, because it was obvious that she was going to have her baby really soon, and she was pushing. And she just threw herself down on the kind of floor mattress. We've got a thick floor mat down, like cub beds in the birth unit. And she just basically flung herself down there, lay on her side with her legs closed and pushing. And we were watching. The student midwife was desperate to go and lift her leg up for her. And I said, no, wait, don't need to do that. Just watch. And we can see a bit of the baby's head now starting to come through. And it's starting, every push is starting to come through a wee bit more because we're behind her and we can see this, the perineum's bulging. The baby's head is starting to emerge very slowly. Her legs are still closed, lying sideways. Her legs are closed together. And the student midwife's having kittens. She's like, I need to go and open her legs. I said, no, just wait, just watch. And because that baby was coming, there was no problem at all. That baby was emerging. And just as it started to crown, she lifted her leg up and said to her partner, hold my leg up. And the baby was born. The baby's head was born just at that moment. And so she knew, we do, as women, we know we can birth instinctively if we are given the freedom to do that. And that's the whole point. And I'd like to say that the most important thing is that women and birthing people are given the freedom to give birth instinctively and physiologically as they want. And they don't need assistance in that way from us unless there is an issue. And so if there is an issue, then we can step forward and suggest and perhaps make some recommendations about some positions and techniques to aid and support her. Otherwise, we don't need to do anything. So all the things that you're going to learn, only use them if you need to. Don't just use them willy-nilly. We don't want to, because this is an intervention. It's a gentle intervention, but it's still an intervention. So we must take care not to interfere in the process, not to replace the biomedical paradigm with another one that is still interfering with the physiological process. So only if it warrants this gentle intervention that will aid birth because she's struggling. And of course it will be with her permission and her consent. So also we can't really dictate which position she should be in. I mean, she can be in whatever position she wants. We know that upright is a very good one because it opens up the pelvis and so on, and we've just felt what that does. And if you go back into that position, put your hands back under your buttocks, you can feel the ischial tuberosities. I want you to feel what it feels like when you rotate your femur. So rotate your femur inwards so your toes start to point towards each other and your knees start to point to each other. And you find that the ischial tuberosities widen. So let's do that again, back to parallel. Open and wide to feel what the midwife is saying, open, and it doesn't work. But now rotate your legs, your femurs inwards, with your toes pointing to each other and the knees pointing to each other. And you find that opens the space. Now, we can know that, but we don't need to recommend that because, as I said before, if the woman can give birth instinctively, she will do what's right for her, and that is the most important thing. She might not choose to be upright. It might be a better position for her to be lying down. It might even be a better position for her to be lying on her back. That will be right for her. But we have to use our skills to know whether or not is she doing this because she feels that's what she ought to do, or is she doing it because it's instinctive and it's right for her. We'll have to work that out at the time. I remember another young woman coming in. She was fully as well, and I advised her to perhaps get on. We had a bed. We had one bed because women actually asked, they requested a bed for the birthing unit. We didn't have beds, but we got one because it had been requested. And so I advised her to perhaps kneel on the bed and lean over the back because I knew this was right, that she was going to release her sacrum and have more space. And then I handed her care to the midwife who's allocated to look after her. And I left the room and I was called back. About an hour later, the baby wasn't coming. So she was still in that same position, kneeling. And I thought, oh, well, I think we probably me to advise her to move. Change position will probably help. And suddenly she just said, I've got to get out of this position. And she threw herself round and lay on her back. And that was the position she wanted. And the baby was born very shortly afterwards. So for some women, that will be the right position because of where her baby is lying. And she will know that. But only if we have an atmosphere and an environment that facilitates freedom of movement and respect those choices that the women make for themselves. So you're nearly finished with this. I'm going to just have a little look at a video that just describes, as an animation, and it describes nutation and counter nutation. So that's the end of the pre-recorded session, and I hope you found that informative and interesting. The next session, in fact, the next two sessions really are going to be live, but they're going to bring everything together. So anatomy, detailed understanding of anatomy and physiology of the pelvis and the surrounding muscles that pass through the pelvis will help you to understand how space can be restricted and resulting in the baby contorting itself to get into the only space available. And I'll just reiterate, because it's worth saying again, that babies do know how to be born. They have it in their blueprint. And as soon as space is released and the restriction is eased, the baby will take up an optimal position and be born, sometimes fairly quickly. Or at least it will reroute the labour into a more comfortable and more straightforward process. So I look forward to seeing you in the live session, and we will do some brainstorming. We'll have breakout rooms. We'll have discussions to explore what we know now and where the gaps in our knowledge are. And we will attempt to fill some of those gaps to make a better picture of what's happening in a labour dystocia that is disrupted by a biomechanical issue. We'll also, in a second live session, we will then go through the positions and techniques which will actually help to ease those restrictions, open up the pelvis a little bit, even just temporarily, just for the need of that moment. It won't resolve long-term issues, but it can actually increase the space. And it just needs to sometimes just be a little bit increased for it to work, as I said at the beginning, almost like magic. So see you soon. Bye-bye.